Welcome, Dr. Tsang, and good evening. Can you give us update of COVID first, and then we'll go for the questions.
Sure. So good evening, everyone. Thank you so much for having me today. I will be covering for Dr. Leung, our public health officer. I've met some of you in other settings, and I'm excited to be able to present some of the information this evening, and I hope we have a great conversation. So just some general updates. We have seen since June 15th, when we opened, we have seen a slight uptick of hospitalizations here in Riverside County for COVID-19. And so, that is something that we are closely watching. We know after the 4th of July weekend, we anticipate a slight uptick as well. We have seen hospitalizations essentially go up by essentially 20 to 30 admissions across Riverside County, which, compared to the winter is not awful, but it is something we are tracking and trending. The admissions tend to be younger patients, and we are watching the Delta variant very closely, as we think that many of the patients may have the more contagious Delta variant. Some other news, COVID vaccination is still widely available throughout the county, at the pharmacies, at many of our mass vaccination sites. There are still some sites that are up and running. Many of your offices are now offering COVID vaccination. Thank you so much. Dolores can probably provide a ton more information about how to enroll. If you're not already enrolled, we highly encourage you to please enroll, because we want to make COVID vaccinations like flu vaccinations, and where patients normally go to get vaccinations is at your offices. And so we want to make sure we're engaging our patients where they seek care, and that we can provide them what they need at that visit, instead of having them perhaps go to a different site to get their vaccine. And plus, they trust you, right? And so we want them to be able to have that conversation with you and then get the vaccine. I know with my patients, they won't get the vaccine unless I have that conversation with them and they ask me, should I get it? And I absolutely say, yes, you should get it. So just a plug for getting your own vaccines, and we can talk a little bit about that. I think there might be a question in the questions tonight regarding the storage pieces. Other than that, we can jump right into the questions and then, open it up for chat.
Our first question is, what is the current thinking on incidence and severity of COVID-19 in teenagers and young children?
Yeah, so, we've been watching that and trending. So every time we, as you know, if somebody tests positive for COVID-19, we collect the demographic information and trend it. So what we've seen is that for the most part, the good thing is the severity of COVID-19 in teenagers and young children is mild. We have been trending cases of MIS-C, or the severe kind of multi-system inflammatory syndrome that can occur with COVID-19 in children. Luckily, the incidence of that is quite small, and most children have very, very mild disease. I think the concern, and teenagers as well do fairly well. I think the concern, though, is that they become the spreaders, right? And so we want to make sure that our teens that qualify, are 12 and over, that qualify to get vaccinated, continue to be encouraged to be vaccinated, because we can at least make sure that we can vaccinate that population. It's our younger population that's a little bit harder, because the vaccines are not available for them yet. And so for my own kids, I have a 7 and 11-year-old. I encourage them to continue masking whenever we're around people that are not within our immediate family, to protect them against COVID-19. Despite all the openings. So, I think everyone needs to come to their own conclusion regarding that, but the science does show that the masking does protect them. And if the children cannot be vaccinated, their symptoms are mild, but it's who else they can infect that I'm also worried about.
Next, when is the vaccine expected to be approved for children under 12? What adverse reactions are being reported during the testing phase?
Yeah, so I wonder, Dolores, is it okay if I share my screen? I thought that was a great question, in terms of when kids can be vaccinated. And, I'm looking all the time too, because as I shared with you, I have young kids. And so, Moderna first announced their participation in phase 2-3 study for COVID-19 in the pediatric population on March 16th. They started their trials. they're expected, they're looking at the 6-month to 12-year range, but their timeline for the study is actually quite long. They don't anticipate being ready to vaccinate in the 6 to 12 months for another year and a half, because that's how long their study is planned for. So they're looking at, mid 2020 to release, 2022. We're in 2021. So in 2022 to be able to release Moderna for the 6-month to 12-year age range. I have a feeling they're going to want to speed up their time frame, because Pfizer, their competitor, is going to be coming out much sooner. But they're looking to enroll 6,750 patients, and there's actually clinical trials here in the Los Angeles, greater Los Angeles area that they're recruiting for as well. Okay, so Pfizer, they're probably the closest to getting the vaccine on the market for the 6-month to 11-year-old, or, essentially covering the 6 months and up, because right now they're already approved for 12 and up. So they plan to enroll about 4,500 children. Actually, they've already enrolled 4,500 children. You can see they've enrolled, in different continents. And so it's an international study. They're thinking that they're going to release September, October. So, many of us are hoping that they'll actually release sooner, before the start of the school year. But it looks like they'll be looking at September, October to seek EUA from the FDA for approval. And that will be for the 5 years old to 11-year-olds. The 6-month to 5-year-olds, the really cutie pie little ones, will be a little bit later. But the 5 to 11, the school age kids, I think they're hoping to release by the fall, so that we can vaccinate those kids, those school age kids. So I just wanted to share, those are the 2 studies going on right now for the approval process for children under 12.
The next question we have, thank you. After a patient has tested positive for COVID-19, as well as being symptomatic, when is the best time to get the COVID-19 vaccine?
Yeah, so what we say, and this is what I do in my practice as well, and in the mass vaccination sites that we've helped to coordinate and manage, we say after the acute phase is over. So as many of your patients may have a longer acute phase if they were hospitalized. The isolation period is a little bit longer than if they were not hospitalized. And so we tell our patients who are seeking vaccinations to wait until the acute phase is over and they're out of isolation. So those are kind of the 2 guides that you should use for, when's the best time for getting the COVID vaccine. So for example, 10 days, usually 10 days, they're out of quarantine, out of isolation. So after 10 days is the minimum amount of time if they're COVID positive. 10 days after their COVID positive diagnosis is when we would recommend vaccination at the earliest.
Is it inevitable that a booster will be required at the anniversary of fully vaccinated individuals? Should we have some contingency planning in the county if this was to arise?
We've actually been watching that, because we are wondering the same thing, right? When do we need to do crazy mass vaccinations again if we have to? The mRNA vaccines, and even Johnson & Johnson, is actually holding up quite well against the variants. And they have been studying the effectiveness of the vaccine. And again, it's only as long as we've had the vaccine, right? Which is, less than a year, essentially. So actually, it's been more.
6 months.
Less than a year. So, we don't know. I think right now I would be taking a guess, but there's really not any discussions around, definitive plans for boosters at this time, because it's showing that the vaccines are still effective. And there's been some even, I've read some literature saying that it might even be effective longer than flu vaccination. So it might not even be seasonal. It might be more like, I think there was an article out recently, more like measles vaccines than flu vaccines. So I think time will tell. I think it's a little bit early to tell right now.
Yes, there was some talk of giving it along with the flu vaccine in a single dose vaccine. So nothing has happened to that yet, huh?
But that would be wonderful.
Okay, great. We are hearing that vaccinated people are getting infected with COVID and dying. Could you provide an update, please?
Yeah, so, we are seeing breakthrough cases, although, you know, the definition of a breakthrough case, you have to make sure that the patient meets the definition. So, you know, and if it's okay, I can share my screen again with you. You know, I tried to put some statistics for the group because I know the group is quite interested in some of those pieces of data. So, you know, making sure you have the right definition for that patient is important because we can't define a breakthrough case unless these things apply. So a vaccine breakthrough infection, right, is defined as a detection of SARS-CoV-2 RNA or antigen in a respiratory specimen collected from a person greater than 14 days after they have completed all recommended doses of an FDA authorized COVID-19 vaccine. So if it's 13 days, they don't meet the case definition. Okay, it has to be greater than or equal to 14 days after they've completed the series. Now, if they meet that definition, we are seeing breakthrough cases. And so let me share with you. So this is from the CDC. This is as of June 28th. We've seen that there's been about, you know, over 154 million people in the United States have been fully vaccinated. So if you remember the case definition, they have to be fully vaccinated and then 14 days after that, right? So, you know, the CDC receives reports regarding fatalities, especially around the breakthroughs, because I think that was the question was, you know, people who are vaccinated, who are getting infected with COVID-19 and dying. So that's where the breakthrough is the definition. And then now have they died subsequently. So you can see here that hospitalized or fatal vaccine breakthrough cases reported to CDC was 4,686. So I took the liberty and did some math, okay? Because if you read down here in the asterisks, 1,240 of those 4,427 hospitalizations reported as asymptomatic or not related to COVID-19. So they died for other reasons, but they happen to have been vaccinated and they happen to have tested positive, but they were probably asymptomatic and their death was not related to COVID-19 and it wasn't attributed to COVID-19. 223 of the 879 remaining fatal cases were reported as asymptomatic or not related to COVID-19. So if you take all those numbers, right, of the 4,686 reported fatalities of patients who were vaccinated, met the case definition, and then subsequently tested positive again when they were hospitalized, if you remove the 1,463, so I just took this 1,240 plus 223, subtracted it from the total cases, right, 4,686. And then I divided that by the 154 million people who have been vaccinated. The rate is 0.00002093. So that's the rate, okay, tiny. You know, I think we have a higher chance of winning the lottery, right? So and not to say that this is, you know, a funny topic, but I'm sharing with you that the likelihood of vaccinations are still the safest choice. So, you know, getting vaccinated and encouraging everyone to be vaccinated is the safest and the best way to avoid hospitalization and death from COVID-19.
Thank you for explaining in a very nice manner. The next question is, when a patient who has received the COVID-19 vaccine gets reinfected with COVID-19, when is it safe for them to be seen them in office? Do they need a negative test?
So they don't need a negative test. So if a patient is test positive again, is reinfected, and then when is it safe for them to be seen in the office is the question. So, you know, we would treat them like, just like before when a patient was positive for COVID-19, we didn't have vaccinations yet. 3 months passed by, they reinfected themselves somehow. You know, we would follow the same discontinue of isolation protocols. So, you know, the CDC still has the same recommendation. They shouldn't be seen in your office until they've been cleared from isolation. Okay, that's a minimum of 10 days from symptoms, from their symptoms. So, you know, you can see here the case definitions here, and I can share the slides with the group. If you'd like, Dolores, I can send it to you.
Great.
And I have the link to the native source there. But again, I would treat them like they were positive and then wait till they're done with their isolation course and their acute phase of the disease. And then after that, they should be safe to come into your office because they're out of isolation. They don't need to test negative. And in fact, the CDC actually recommends we do not do testing because they could continue to test. The mRNA, you know, the swab, the nasopharyngeal swab, is so sensitive, right? It picks up that RNA. And so you could inadvertently extend their isolation for a really long time. We've had some patients that test positive for, you know, I think I had one that tested positive for 6 weeks, and I just said, stop testing. Like you're not, you no longer, you've cleared, you know, you've already like finished all of your discontinuation of isolation protocols, you know, but every time you test, you keep testing positive, and then we can't, you know, this starts over. So, you know, it is, we don't recommend testing.
In fact, even the dead virus will test positive, right?
Yeah. So a test-based strategy is not recommended.
Okay. The next question is, in our hospital, COVID-19 EUA infusion center, our last 3 patients have been fully immunized and are presenting with a positive test and new onset symptoms. We aren't the site that tested them, but should we obtain an NP specimen and send it to the state for further analysis?
So yes. So, you know, I think that's a great question. So if the originating site that they tested it didn't send it, you know, I would recommend that you do send it. I have breakthrough cases. Please send to the public health lab. So, you know, there's protocols. And if you're, you know, you can ask if they tested through a commercial place, you know, they may not realize that the patient had tested positive. So there's no, I think it would be great if you have the ability to retest them and send it to the public health lab so we can send it to the state lab for whole genomic sequencing. And that way we can see what variant is maybe causing those breakthroughs.
Great. The next question is for COVID positive patients that only have a single symptom of cough. Can we bring them in office for an appointment?
So that's a great question, because we do know that there's some long haulers that have kind of residual symptoms, right? And so, you know, if they have cleared their isolation period, you know, my recommendation is if you're uncomfortable seeing them, right, because you are ultimately, you're the one who has to decide what the comfort level is, you can do a telehealth visit with them. You could also consider, if they've cleared their isolation, you can consider putting them into a negative pressure room if you have that available, and then, you know, wearing PPE. So, you know, that's my recommendation. But if they've cleared their isolation period, they should be safe to come into your office, you know, with proper PPE precautions if they're still coughing. So masking, which they are recommended. We still, Cal OSHA still says to mask in a medical setting. So I hope that answers that question.
But it's probably safer to do a telehealth visit too.
You know, if you can, you know, I always say if you're uncomfortable and you can offer a telehealth visit, you know, absolutely, you can do the telehealth visit as well.
So we got the answer for 9 also. What are the current CDC guidelines for COVID-19 in a medical practice setting where all the staff are vaccinated and patients are vaccinated?
So I wanted to share the Cal OSHA slide. So the recommendation is in a healthcare setting, everyone should be masked, because you don't know who's vaccinated, you don't know who's not vaccinated, you know, especially with the Delta variant right now. You know, Cal OSHA is saying, you know, face coverings are required in a healthcare setting.
The next question is, can we as private practice office mandate that all employees be vaccinated? What are the legal ramifications?
You know, I thought that was a really interesting question. So I'm not a lawyer, so I don't want to provide any legal advice. But if you have a lawyer, you can please ask that question. Currently, there's not a mandate in place for mandated vaccinations. If you're in a private practice or a private setting, you know, private places can mandate different things than public places, right? But there's not a Not that I'm aware of any kind of vaccination mandate that's out there. But private practices and private settings can do things differently. So my recommendation would be to check with your legal counsel to make sure that whatever you're looking to do in your practice makes legal sense.
Thank you. What are the guidelines for allowing people other than the patient in the medical office, waiting rooms and treatment rooms?
Yeah, so that's a great question too. So we, in my clinic, we allow them to have a guest with them, especially, for sure with children, you want their guardian with them. But we are allowing a guest. We don't want the room to be crowded, so we usually allow one additional guest. There's not clear guidance around that. The CDC, I was trying to read to see what the CDC recommendations were, and most of it was around nursing facilities, post-acute settings, hospitals. So I think clinics, ambulatory clinics are not, there's no hard and fast rule for ambulatory outpatient clinics. So I think, my recommendation is, still following the safety practices. COVID-19 is still very much amongst us, especially with the variants and with concern for how contagious these variants are and the challenges around verification of vaccination. My recommendation would be to minimize exposure to your staff from some of your patients by limiting how many people come into the room with them. If it's a mom with her 4 kids, I mean, that's different than, because they're all within the same household, right? Rather than, maybe a friend with 3 other friends. So, just using a little bit of common sense and sticking to the safety precaution protocols that you put in place, as part of COVID, I would still try to stick to that.
Great. The next question is, could you please provide guidance on Delta variants, testing, treatment, safety precautions in clinics, vaccine efficacy, or any others?
Yeah, so, right now the testing, it's still the same recommendation. If they're symptomatic, test them. And then what the state is trying to do is do more sampling of, the tests that are being collected for COVID-19. If they do test positive, they're trying to do the whole genomic sequencing to get a better idea of what the prevalence of the Delta variant or any kind of variants of concern are here in California, and especially here in Southern California. Well, that's my interest. So it's the same guidance regarding testing. If you're symptomatic, or if you've been exposed, please test. Treatment right now, we are having some challenges around our monoclonal antibodies because of the variants that are floating around. BAM, which is what we were using before, you can't use anymore, right? And so, it's actually causing us to not have some of the EUA therapies that we had, even though the effectiveness wasn't, very definitive, but it was still giving our patients something additional. Remdesivir is still working. You can still use dexamethasone. So the 2 treatments when you become hospitalized are still the same treatments, but some of the monoclonal antibodies are no longer effective or are not recommended to be used because of the variants.
The next question is, surveys indicate more than 73% of patients trust their physician's advice to get the COVID-19 vaccine. Do we have an opportunity to get vaccines to MD offices so as to increase COVID vaccine rates?
So, we're very lucky because Dolores is our here with us and can guide us through that process really nicely. She has some great resources. So if your office is not already approved to receive COVID vaccines, please work with Dolores to get yourself approved. You can also work with us through public health. We have a way to also help you get approved to be a vaccine provider. I do encourage everyone to be able to get vaccines into their clinics. I think there was a question regarding storage. The beauty is Pfizer now makes smaller packages. So if you still see my screen, I'm going to go through just some basics of vaccine storage around Pfizer and Moderna. Pfizer used to come in the 1170 pizza trays, if you've heard that term. They've actually decreased the size now to 450. So 450 doses instead of the 1170. So it's a little bit more attainable and accessible for, smaller practices, not, we're hoping to target. So The other thing is the storage is less onerous. So you don't have to have, the super fancy ultra low temperature freezer anymore. You can actually use a regular freezer, and that can store between 25, negative 25 to negative 15. That's right, Dr. Singhvi, you're right. So negative 25 to negative 15. And if you store it in the freezer at that rate, you can actually store it for quite a long time. So, you can store it for 2 weeks in the freezer and then move it into the refrigerator. And then if you move it into refrigerator, you can keep it between 2 and 8 degrees Celsius for another 31 days. So from freezer to refrigerator, you have a total of 45 days to use all that vaccine. Now, if you're saying, I don't know if I can use 450 doses, that's okay. Right now, through the CalVax, MyCAVax, you can actually order smaller doses, and the public health team will coordinate with you to receive 100 doses of Pfizer. And then you could then store that for 45 days and use your 100 doses. So there's lots of options available. We just want you to get vaccines into arms. And so we will support, we've given as small as 50 doses to a practice, and so, please communicate with us in public health if you want smaller doses than what the true package comes in, and we can get you smaller amounts as you need them. Once you're MyCAVax approved, we can't do it before that.
Just before we leave the vaccine issue, just to let everybody know, if you are not already signed up or enrolled in the vaccine program, we actually have a staff person that is working as a personal concierge, if you will, for practices that will help you move through the process quickly and make sure that it's done correctly, so you can get signed up right away and streamline the process. You probably heard stories from the past that it would take weeks or months, and it was a big hassle. We have a person dedicated to helping you through this process. And the other thing, to encourage providers to become vaccine sites, there is now a grant program available of $10,000 for a single site and up to $50,000 for multiple sites. And that money is available on a first come, first serve. So I highly recommend it. On the resources, you will see there is a link where you can apply for the grant. And it doesn't have to be new providers. It can be if your practice has already been giving vaccines, because it's to help you with the cost of being a vaccine site. So again, I strongly encourage everybody to be a vaccine office, and we can certainly help you at the RCMA.
Before we get to the questions in the chat box, I think there was a part of the question regarding the Delta variant that I didn't answer, and I want to make sure I answered it, because I think it was regarding vaccine efficacy. And I think that's a hot topic right now. So, what we're finding is that the mRNA vaccines and the Johnson & Johnson vaccine is very effective, greater than 90% in preventing severe illness. Okay, so meaning you won't get hot, you won't be in the ICU if you get vaccinated and get Delta. So that is, I think, amazing if you think about the efficacy of the vaccine against the variants. You could, the transmissibility though is much higher. So, I think the breakthrough could be up to 60 something, I think the effectiveness of the vaccine is up to 60 something percent against the variants. But the severe complication piece, protecting you against severe complication, is greater than 90%. So I just wanted to touch on that.
Right, thank you. Okay, and do you have a few more minutes for questions in the chat?
Sure.
Okay, thank you. So first question, any update on vaccination for the homebound and bedbound patients in the community palliative and hospice programs?
Yeah, so probably at the end of mid-June, we offered, we contracted with an organization that will vaccinate homebound, bedbound, palliative, and anyone who cannot leave their home for vaccinations. We contracted with a company that will do that. So if you go to myturn.ca.gov and you go in there and you put that you're homebound, what happens is that the state will send us a list every day. There's usually I can share with you, about 20 to 30 patients on that list. We send it to the company we've contracted with. They will call and reach out to the patient, schedule a time, and they'll send a nurse to the home and vaccinate that patient.
Okay, next question. Do we still need to do contact tracing on indoor groups? And if so, what group size is required for contact tracing?
So that's a great question. We actually still do case investigation and contact tracing on all of our positive patients. So there's not, even if it's one individual, we'll do contact tracing.
There is national news on a summer camp group becoming sick with COVID. Has anything like that happened in Riverside County or neighboring counties?
Not that we're aware of, thank goodness. There was a case up in Northern California where a school group was infected because they were indoors and unmasked. And so, but not in Riverside County that I'm aware of. And yes, that summer camp group made big news, didn't they?
Right. Okay. Are there any specific additional precautions required for the Delta variant for overnight camps?
I think that is a hard question, right? Because, I think if you're vaccinated, that's not so much the issue. Overnight camps tend to be for kids. And if your kids aren't vaccinated, that is a challenge because there's a risk for them to become infected, especially if they're not consistently masking. And, currently, the mask mandate doesn't apply to outdoors or non-medical settings. It's not required, it's recommended. So I think that becomes, we're watching that very closely because we are worried that with the Delta variant, we're going to see an increased number of cases. My precautions would be, that's going to be an individual decision that needs to be made by parents if they're sending their kids to overnight camp who are not vaccinated. I can tell you, I wouldn't, just because the Delta variant is so, we're just discovering this. And so, it's a wild card that I wouldn't expose my children to. But I think every parent needs to make that decision unless you're the parent going to the overnight camp. If you're vaccinated, you're good. If it's an all adult camp and everyone's vaccinated, that's okay. But for kids, I think that's harder.
Okay. And the last question that's in the chat box. For those who are immunosuppressed or have received steroids at the time of the vaccine, have there been more infections, and are there any additional precautions or a need for a booster vaccine?
Yeah, so what I tell my patients who are immunosuppressed is that, their immunity, right, will wane. And you guys know this better than I do, as some of you are specialists out there who take care of way more immunocompromised patients than I do. But we do know that their immune system doesn't have as robust of a response as someone who is not immunocompromised. And so I do tell my patients who have some kind of immunocompromised state to continue masking and to be very cautious around people who are not vaccinated for that reason, because we just don't know how long their immune response will hold on to, we just think that there's a waning that happens much faster than the general population.
Okay, I'm sorry. One more question came in that we have not addressed in the past. So if I could just slip that one in real quick. It says, are we developing strategies to differentiate between flu and other respiratory infections for clinics and hospitals during the fall and winter of 2021? Will there be sufficient testing available without long turnaround if we see a spike?
Oh, so that's a great question. So some of us have the capacity to do the respiratory viral panel. So if you have BioFire capacity, Quest has BioFire capacity. Some hospitals have BioFire capacity. What that means is that you can do a full respiratory viral panel. So for example, for our hospitalized patients, sometimes we'll run the full viral respiratory panel within BioFire. So it looks for the other coronaviruses other than COVID-19. It looks for RSV, it looks for flu, it looks for, all the ones that we can test for. And that way we can see what virus that patient might have that's causing the respiratory infection if it's not COVID, right? And so, you know, there are the capacity to do that, but I don't know if everyone has access to that in their office, but I do believe Quest will run that BioFire panel for you. I don't know the turnaround time. We know that usual turnaround time when it's not crazy is maybe 2 to 3 days, but during the spike of COVID, we were out to 10 days sometimes to get those results back.
Okay, I will turn it back to Dr. Singhvi.
Thanks, Dolores, and thank you, Dr. Tsang, for a very informative and productive session. And I'm sure our membership appreciates that. Our next meeting will be on August 12th, same time, Thursday, 6 p.m. Thank you very much, and have a very good evening, and stay safe, please.